Greetings from eMedi News and IGCP Group. Welcome to our show, a panel discussion on chronic constipation. We have chosen this subject of chronic constipation as it's very common in our clinical practice, and every physician, family physician must know how to manage. Most of us have been mismanaging chronic constipation. We must know when to use a bulk purgative, when to use a osmotic purgative, and when to use a stimulant purgative. No stimulant purgative unless the osmotic purgative fails. That should be the message. With that, we are going to start with this panel discussion and going to have some take-home messages in the last. You will understand in the next couple of hours when we discuss about constipation, a topic which is easy to say that I know everything about constipation. It really needs challenge to understand this topic and treat this patient. To discuss this topic, we have an eminent faculty. There are no slides, there are no lectures. In the first session, I will be interacting with my faculty and ask them questions on your behalf, and then we will have open house discussion. Let me introduce my faculty. We have Dr. Kailash Singla, then we have Dr. Rajiv Khosla, Dr. Colonel S.K. Thakur, then we have Dr. Ajay Kumar, and that will be Dr. A.K. Jhingan. Dr. A.K. Jhingan being a diabetologist, I being a cardiologist, we will cover the non-GI part of constipation. And all of us are going to be interacting with each other. So, starting from Madam, what is the definition of constipation? What do you feel is the definition of constipation?
One, no stools for 2-3 days. No stool.
No stool for 2-3 days. 2 days or 3 days? 3 days, okay. So twice a week somebody is having a motion, according to you is constipation. Thank you. So Dr. Saab, what is constipation?
Constipation is a stool twice a week and it's a hard.
Hard. So he says twice a week and it should be hard. Okay. Second definition. Third definition. Yes, Vishnu?
I think it should be changed how the habit changed.
So he says changing in the habit is a constipation. So if a person was having motion every day, now he is having alternate day, there is a change in habit. According to him, that's constipation. Anybody else?
Not able to pass the stool in next for 72 hours.
Excessive straining while passing, unsatisfactory.
Unsatisfactory feeling.
Incomplete.
Incomplete evacuation.
Sometimes it is the perception of the patient. He may be going 2-3 times in a day and still say that.
So a person may be constipated and still he may be passing 2-3 times in a day. That's a constipation. Interesting.
Patient may come and complain of constipation,
but actually he is not, according to him. Okay, that's interesting. That's interesting. Let's listen to all 5 of us and see whether all 5 of them can speak out one language or not.
You know, I am most impressed with this audience. This constipation has been debated for a very long time, and there's a group of very eminent gastroenterologists from all over the world who collected on many occasions to make an accurate definition of constipation. This took 3 conferences. These were held in Rome, and the first definition was called the Rome 1 conference. Then some years later they said this is wrong, we make it Rome 2, and finally recently there is a Rome 3 conference. So what is the Rome 3 definition? The Rome 3 definition is that these criteria must be present for the previous 3 months at least, and must have started at least 6 months ago. In other words, if someone has constipation for 1 week, that is not chronic constipation. And what are these criteria? At least 2 of the following 6 should be present. And the first of these is that straining at stool at least 25% of the time. Number 2, lumpy or hard stool at least 25% of the time. Number 3, incomplete evacuation feeling at least 25% of the times. Number 4, a feeling that something is stuck in the rectum in at least 25% of the times that you pass stools. Number 5, resorting to manual evacuation, using your finger to pull out stools because you are feeling irritable at least 25% of the time. And number 6, as Madam said, less than 3 bowel movements per week. Any 2 of these 6. Let me go.
My friend Rajiv has summed up the whole definition of chronic constipation very well. But we must remember there could be an acute constipation as well. I mean, acute constipation can be sometimes more sinister to begin with. And I just want to highlight one of the issues that he has said, because that's clinically relevant, and what we call as a feeling of incomplete evacuation. See, on one side you say the definition is of constipation is less than 3 stools per week. But in a patients who have a feeling of incomplete evacuation, they tend to go to the toilet 4 times, 5 times, 6 times every day. According to the Rome 2 or Rome 3, even this came under diarrhea. But because they are only calculating the number of stools, but now there is a thinking change, as we said, a strong debate going on, and this feeling of incomplete evacuation, even though the number of stools is more every day, more than 2, 3, 4, still it will come under the definition of constipation. Dr. Jhingan raised an issue that what is it, how do you differentiate what is irritable bowel syndrome, constipation predominant? The key difference in the two definitions, it's a very academic distinction. When you have associated abdominal pain and discomfort, then it comes under the heading of IBS, constipation predominant, and when we write IBS-C dominant.
So in the Rome 3 criteria, it is very clear that 2 out of 3 should be present for 3 months. Symptoms should have started 6 months back, and the IBS criteria should not be met. That means the patient should not have pain or discomfort. Pain, constipation, IBS. No pain, constipation, chronic constipation.
Yeah, that rightly said that these two, any of the following in the Rome 3 criteria should be met, and there should be no addition of the pain and
Dr. Thakur, in your practice, if you see 100 patients, how many of them have constipation?
Many of the patients that you get with constipation are actually describing their symptoms as difficulty related to the act of defecation. And there was a study where they have compared by these criteria only about 30% of your patients who are complaining of constipation actually have constipation fitting in with this. Others may be having some difficulty in passing motions which need not be constipation. It could be a feeling of incomplete evacuation, it could be pain, it could be an obstructed feeling. The message is, please hear your patient, do not start prescribing until a time comes when you have been able to interpret what he means by constipation.
Is there any change in definition in diabetics?
No, I don't think, but the patient perception is definitely, which I agree with Dr. Thakur, because most of the time they have a different symptoms and they will always say that this is a constipation.
Is large intestine so important that if we can clean, detoxify the GI tract from top to bottom, we can take care of as a preventive measure of most of the diseases? I'm not going into controversy of Ayurveda versus naturopathy.
I think in the allopathic system of medicine, there is no such thoughts that everything is a root cause is the large intestine. That's the only thing I can mention. I'm not a student of Ayurvedic system, so I cannot comment on that. Yes, I am aware the importance attached to the evacuation process in the Ayurveda system or a naturotherapy.
The idea of introducing Ayurveda was that we should not have the idea that constipation chalta hai. Chronic constipation needs to be treated, whether we believe on Ayurveda or not. And Ayurveda only says is, if chronic constipation is not treated, you may end up into lots of other ill health, your immunity may become low.
I think there is a difference in the two sciences understanding the thing. There's no doubt that any chronic constipation needs relief, comfort. But we are not talking about chronic constipation when we are talking about that it's essential to pass a stool every day.
Sir, I'll just add one word to this. We are all doctors who are treating patients. At the same time, when a patient comes to you with constipation, many times he is physically disturbed and a lot of times he is mentally disturbed that he is retaining toxic products. But I think as doctors we should reassure him that if he does not pass motion 1 day or 2 days, we must reassure him that he is not creating poison in the body. It's not going into his circulation. He is not going to be poisoned.
We have talked about the definition of chronic constipation. Now we come back to risk factors. To start with risk factors,
if you look at the literature, most of the risk factor profile unfortunately is based on data from the West. One basic risk factor is increasing age. older people are more likely to get constipation. Number two, in the West, it is said females are more common. In Indian figures, often men have more constipation, so probably it's equal over here. Number three is reduced physical activity. Number four is, very strangely, lower socioeconomic status. And number five is medication. So 5 things. Increasing age, probably male females are equal, reduced physical activity, medications critical, and perhaps low economic state.
I'll start from the drugs. Ajay, what about drug-induced constipation?
This is a very important issue. Drugs are one of the most important reasons for change in bowel habits either way. And the commonest ones are antidepressants, anticholinergics. Actually, most of the antidepressants will have an anticholinergic effect. And even the anti-diabetic medicines, like though metformin causes more of dyspepsia, but it can cause a change in bowel habit. Then drugs, both Parkinsonism as well as the drugs used in Parkinsonism will cause constipation. Calcium channel blockers. I mean, there is a long list of medicines, but most important are these 4 or 5 groups which we should remember. So I think that is the most important part in evaluation of any patient of constipation, to evaluate the drug history. It needs spending time. Unfortunately, in India, most of us, while in our clinics, don't have that much time. But I think that's the most important thing.
So that's important. There are lots of drugs. If anybody wants to add few drugs, Dr. Singla?
Then opiates.
Opiates. So opiates, if you are taking any painkillers and opiates.
I think antacids are
Antacids.
misused group of drugs, which is also a very common cause.
And the 2 other ones, of course, non-steroidal anti-inflammatories, painkillers often cause constipation, and the other drug that has many side effects, either constipation or diarrhea, is iron. Sometimes, rarely, diuretics can also cause it. Remember, a lot of heart patients are on furosemide or other diuretics. For various reasons, including dehydration, they can cause constipation.